Mike, Justin, Terris, welcome to the podcast. Super excited to work with the three of you today. For people who aren't familiar with you, would you mind filling them in a little bit about who you are and all the amazing stuff you're doing around this foot ankle world, if you will?
Thank you, man, for getting me on here. My name is Terris Hightower, currently function as a foot and ankle pathomechanist, primarily in research and application of detailed biomechanics and as it pertains to injuries. More specifically, I have a background in basketball, so a lot of my foot and ankle bias is also more so funneled towards the basketball space. I spent 3 to 4 years working with the Washington Wizards, Washington Mystics, and the Capital City Go-Go in various different roles depending on the season, whether it be strength and conditioning, sports science, or rehabilitation. Yeah, man, I'm just really excited to be on here and to learn from the rest of the gurus we got on here.
All right, I'm Justin Lewis, podiatrist, specialize in surgery and sports medicine. My background is bachelor's and master's in exercise physiology, so that's always tied into my practice. With most of us clinicians, we focus on clinical things, and many times we just suggest surgery, but finding the root cause of things has always been a struggle for some clinicians. But it's been a passion of mine just because of that background that I do have with the undergrad and graduate degree in exercise science.
Yes, my name's Mike Lehr. First off, Dan, appreciate you having me on again, repeat offender. At that point, love to see how you evolved over the years and the good work you're doing. So appreciate being on this with some esteemed colleagues here. I'm an associate professor at Messiah University. My first interest in foot and ankle probably started about 15 years ago. Since that time, most of my research studies to clinical trials revolved around how the foot and ankle has impacted movement patterns, and then also literally what interventions increase mobility at the ankle. So for the most part, I'm a PT, associate professor, manual fellow. So my specialty is in manual therapy. Also, in terms of exercise, I'm looking for any kind of interventional model to increase the function of the foot and ankle and how it impacts human performance. So thank you for being.
Absolutely. Yeah, no, I think that's amazing. And obviously, the three of you share this common ground of having strong interest in the foot and ankle for one reason or another that way. And ultimately, this is probably the like 20% of the body region that I think dictates the remaining 80% of function. Everything from a lower extremity standpoint, anyway, starts from the ground up. And I think now more than ever, we have to be looking more into how our foot interacts with the ground for any one of these, really difficult types of problems that we have to solve in the athletic population, whether that's Achilles injuries or ACL injuries or any of these other lower extremity things that continue to plague athletes. I think the foot and ankle holds a lot of value to us because, again, ground-based movement starts from the ground and the foot is the thing interacting with the ground. But as we've previously discussed, a lot of times people overlook or forget about the foot and ankle, right? It's not as cool as what a jacked set of quad muscles looks like. It's not as cool as diving into one of these joints like the hip that does all these crazy motions. It's very complex to try and understand how much is going on at the foot and ankle because there's just so much crammed in there, so many different joints and unique articulations and patterns that way, if you will. And I think a lot of times people they're just scared of it, for lack of a better way to put it, because of how much you need to understand to really apply these concepts well that way. I'd love to hear more just from you all, just to kind of kick us off here about where your interest in the foot and ankle complex came from and why it's so essential for us to really dive in and understand the foot and ankle, the joints, the soft tissue structures, and so on that way for us in our practice as coaches and clinicians.
I'll start. For me, I mean, essentially, it was a family friend that was a podiatrist, and that's how I got into my field. Um, Before that, I was in the graduate track for exercise physiology, but with my background and the way we approach things, it's a little bit different because I see patients of all ages. I mean, 2-year-olds come in, walking in toed, and we struggle with the pediatricians, right? Because we always say, "Oh, they'll outgrow it." right? And then you see adults walking in toad because they didn't outgrow it, right? So having early intervention, addressing pediatricians to try and get someone to assess and not just say, tell the parents, wait, don't worry, don't worry. On the flip side, then you have the athletes, right? The high level athletes that are going nonstop in their teen years, and the parents are pushing them, right? Nonstop, doing camps and camps and camps and no conditioning, right? We run into that a lot. And that's a struggle. And then you have the older generation that we're running into that just, they just, over time, they just waited and waited and things caught up with them, right? The mechanics were never an issue when they were young. Some people are resilient, but then over time, they finally feel it, and they'll be 60 and say, well, I've never had a problem before. Why do I have it now? Well, things can just happen.
I think for me, the one thing that was very intriguing for me is just in terms of injury risk and risk for future injury. Just the fact that the biggest risk factor for future injury is previous injury. I think now we have to look at, what goes into that management. And I have to own that as a physical therapy professional and how that may influence return to sport decisions.
I think both of you guys are hitting everything, especially with the ongoing effects of previous injuries. And that was the thing that got me going. Being in basketball, we all know the polarizing injury is the lateral ankle sprain. And a lot of the times that lateral ankle sprain has been kind of talked about as an easy injury to rehab, an easy injury to deal with. People always talk about the lateral ankle sprain like it's simple. Anybody can handle that type of rehab. And what I started to learn as someone who's in the basketball space, where we're doing measurements preseason and then nothing changes postseason, right? And when we're doing measurements and, we're trying to do all of these things that impact, everybody loves to talk about ankle dorsiflexion. And then we do all these interventions and then nobody's ankle dorsiflexion changes. Or maybe it gets worse towards the end of the season. And I started to realize that there was something that I was missing because we're getting these ankle sprains, we're returning them back to full go, but it seems like they're not returning back to full go because 9 weeks later, I got another ankle sprain. And then 4 months later, they got another ankle sprain. And then we start talking about, okay, what are the negative impacts of these repeated injuries long term? And that's where I kind of landed on pathomechanics. And I started to realize that we're getting morphological changes to these tissues. And once these changes to these tissues happen, the rules change. And we're no longer dealing with the same arthrokinematics that the book talks about. We need to start learning about all the different compensatory changes that occur and how that impacts the other corresponding joints up the chain.
I love that, Terris. I mean, when you're looking at lateral ankle sprains and you're looking at just the recurrence rates too, I mean, even when I'm teaching this, I always ask how many people have sprained their ankle. And, half the class raises their hand. And I say, keep the hand up if you never sprain that ankle again. And then what happens? You just don't have one lateral ankle sprain. Then you have a sort of cascade of events that leads to chronic ankle instability. And I think you touched on a great point in terms of the morphology of some of the tissues and how that tissue has changed. And then also I go with the idea, lack of proprioception. So now the proprioception is altered. So the afferent pathways are disrupted. And now you look at it, I mean, research geek coming up here, but when you look at some of the older, traditional research, they even show in non-painful ankles that had a previous ankle sprain, there they see delayed firing of the hip musculature, which impacts the lower chain, and that's on non-painful. So even just a return to sport decision of no pain, that is only the beginning. And we do know when pain's on board, movement is altered, movement is dysfunctionally altered at that point. And, that can certainly add to the whole dilemma and challenge that we're facing as sports medicine professionals.
Yeah, I could not agree more with that. And just building off what you just shared, Lehr, I had a conversation a few months ago with Gray Cook about this concept, and he had an individual he was assessing the core musculature with. And this individual, on the flip side, actually had a forearm injury or wrist injury years prior. And they found that the left side core musculature was significantly inhibited compared to the right. So to me, it's like if we just flip that and now we're looking at, again, the foot ankle complex, it's no wonder we see issues in the hip and the core and so on that way in relation to where those injuries occurred. And obviously, as you mentioned, a lot of these things just go unchecked, whether that's the lateral ankle sprain or the other one that I hear constantly now is the Achilles tendon. And everyone's trying to figure out, like, oh my goodness, well, it's painful. It's not painful, but it ruptured. Like, just trying to wrap their head around the tendons, because for lack of a better way to put it, tendons seem to be like a very dumb tissue. It's like they hurt for some reason. We can't figure it out. Other times they hurt for no reason and they end up tearing for whatever reason. That way it's just complicated for us to try and figure out that way. Would love to hear your thoughts in relation to the Achilles tendon that way, and some of the initial mechanics that might lead to injury, but also some of the altered mechanics that you might see in relation to pathology that are going unchecked. Or, on top of that, is every Achilles tendon issue that we see actually an Achilles tendon? Or is it something else? Are we calling it an Achilles tendon issue when it's actually retrocalcaneal bursitis or some of these other different pathologies and tissue structures that maybe we forget all about entirely?
I like the question because it opens up a can of worms in terms of where do I start with this question? So for me, I'm the guy that always goes, okay, let's talk about pathomechanics. So let's talk about real biomechanics and let's talk about tissue stress theory. So if we are talking about a tissue that is behaving in a manner, whether it's pain signaling or it's reduction of performance, what is the underlying first principle of pretty much every injury? And it always will go back to tissue stress, right? Where we have high loads that deform tissues, and the integrity of that tissue, or the lack thereof integrity of that tissue, will dictate how that tissue behaves. So if we have repetitive loads that may not be high enough to rupture a tissue, but they may be high enough to damage a tissue. Um, and the stress shielding that may come from that, because we are so adaptable, and that's why everything is connected, that over time, and these tendons will become damaged, they may not hurt, right? They may not have the same stiffness capacity, but we're able to compensate, right? We're able to compensate for however long we're able to compensate, depending on the integrity of other structures. That depends on, okay, how much can your big toe move, right? Or how strong is your FHL, or how strong is your quad? Like, it just depends on all these different components that comes in. And I think where we go with treating some of these things is understanding, like you said, oh, is it retrocalcaneal bursitis? Well, that may be the diagnosis, but it's like, okay, what made that particular structure start to behave in that painful manner? And I think it's just trying to figure out, do we have a good assessment? Do we have the ability to assess the implications of the big toe on the subtalar joint, the subtalar joint on the knee joint, et cetera? Do enough clinicians have a good base in understanding the coupling mechanisms of these lower extremity joints and tissues, from just a pure like ortho standpoint? And I think when we get there, when we start to have more people understand that, okay, if somebody has a knee issue, I need to check the subtalar joint. If they have a knee issue, I need to check their big toe joint. If they're having Achilles pain, maybe I need to check the strength of the FHL. When more people start to go there, instead of sticking to these APTA CPGs, and kind of more leave that culture and go into a new era where we're really starting trying to connect the dots. I think that will make a huge impact on the way all athletes are cared for.
As a clinician, it becomes difficult because when we see an Achilles rupture, we didn't see the patient before the Achilles rupture, right? So that's hard for me. I'm not doing an assessment because they walked in and they can't plantar flex. I know it ruptured and I have to surgically repair it. Going back to the retrocalcaneal bursitis, we see that a lot. A little different demographic, but it does vary the age ranges, but those definitely hurt. They can cause pain, and there's definitely a lot of treatment options there. And those we assess the biomechanics, but again, it comes into the clinician role where we just get this hyper focus on something's torn, let me fix it, and let's let the PTs figure out why it happened, or rehab it, and then let them figure out why it happened. Because a lot of surgeons, we don't assess all that, and we should, right? We definitely should, and we learn it in school briefly, and then when you get in the real world, you go, and you're like, oh, it's you Thompson test, blah blah blah, yep, book you for surgery. But yeah, I for every athlete, I mean, I do assess, from hip down, right? And we do check the hip internal external range of motion in the knee and try to make them walk if they can walk. But yeah, it's tough when to assess biomechanically why something happened, because we usually are coming late to the game, on my end at least.
Yeah, just building off those two, great comments. In terms of Achilles tendinopathy, it is fascinating to me, and I sort of love that muscle and the complex between. I mean, and it goes into, okay, what is tendinopathy? And with diving into the research, you're not really looking at an inflammatory response anymore. They're leaning more towards, oh, geez, if I can recall this, angiofibroblastic hyperplasia or something of that nature, where it's decreased collagen, poor collagen in connective tissue, neurovascular ingrowth in there. So there's a whole other physiological process going on. And when you think about one of my pet peeves, and I made that mistake, you just assume it's overuse because that's easy. And then what happens? That's a quantitative factor. So you cut back on the activity, decrease the time. Maybe, that person is able to go back, but then after a while, the repeated microtraumas catch up. So there, I think biomechanics and pathomechanics really does matter with the Achilles. So first off, what is it? What it isn't? Well, it is an inflammatory process, more uh, collagen, connective tissue quality issue. So then what do we do about it? Well, for me, an assessment, I'm wondering why that tissue is breaking down. So I try to look at, just from my background, just that dysfunctional movement behavior that's predisposing that tissue. And that tissue is designed, at least the gastroc, it's a bipinnate muscle designed to control movements in the sagittal plane, control that dorsiflexion, the explosion of plantar flexion. But what it's, in my opinion, I think the problem is when we start getting into the calcaneus and the subtalar joint, when it starts getting into excessive frontal plane and transverse plane motions. I don't think that tendoperiostral junction is equipped to handle those frontal plane forces, a severe eversion uh, you know, or inversion. And honestly, I think, their excessive pronation, think about how many pathologies relate to excessive microtrauma, Achilles tendinopathy, posterior tib, plantar fascia at that point. And then I go back to how can you effectively address, Achilles tendinopathy? What you see in the literature, eccentric training, that's only part of it. I think of, some going back to manual therapy roots, posterior glide and the talar curl joint, getting back to that dorsiflexion, to take away the need to compensate with the subtalar and mid-tarsal joints for pronation. And then go up to the hip, look at lower extremity alignment, because you can pronate at the ankle coming from if you have delayed gluteal function. So, Dan, it's taken about 20 minutes. I hit dorsiflexion and gluteal. I can step off now. I did my part. Dan's only heard that the same speech like 20 times now. So,
And Mike,
yes, Terris.
so maybe we might go to war right here, where
Okay.
where
Good to go. No, I'm here to learn too.
no, where I started to bang my head against the wall, man, with the posterior glide.
Yeah, yeah. Yeah.
And I started to realize that this wasn't giving me what I thought it was supposed to give me. And this is me speaking about my particular population in the NBA, where I started to notice I mob the talocrural joint all the time. It never changes. I mob it, and I'm not even talking about chronic changes. I'm talking about within the session, I'm not getting the response that I want. Where guys say, "Yeah, it feels a little better," and I hate that. I wanted to go, "Oh my God, you're the GOAT. You're cold like this. I feel amazing." And what I started to realize, and that's what started making me go look actually at the foot. I used to be an ankle guy, and then I started going, "What's missing?" And I was like, "Oh, well, every ankle has a foot on it. So let me go look at this foot." And then when I started to discover the coupling nature of the talocrural joint, I started to realize, hey, there is a little bit more than what I learned in my didactic studies, whether it be PT school or AT school, about this talocrural joint being a sagittal plane joint. There is rotation. There is frontal plane motion. That frontal plane motion is extremely important. And that talus being, the star, and where that talus is, it's a part of the talonavicular joint, the talocrural joint, the subtalar joint, all at the same time. And those joints are actually distinctively different joints. They have different distinctive innervations. And I started to look at, okay, so you mean to tell me that if I have an issue with the spring ligament, that affects my talocrural joint, but the spring ligament is not a ligament that controls the talocrural joint. And so I started to look at, and that leads us all back to Pathomechanics, where my favorite study right now, I want everybody to look at this study, man. It's my favorite study. I like read it like once a week. And it's called Medial Arch Instability, Internal Foot Overload Association with Non-Insertional Achilles Tendinopathy, and the Zone of Conflict Theory. That zone of conflict theory. If you just type that in, you'll find it. And what that study beautifully describes is this chain reaction of things that occur, not only just to this overload, but they start to look at the changes of the subtalar joint axis. And they start to notice that if the subtalar joint axis starts to deviate medially, the different moments that the Achilles has to overcome at toe off starts to dramatically change. And what they start to notice as that subtalar joint axis starts to deviate medially, we start to get instability of the first ray. And then all of a sudden, at toe off, where the Achilles is trying to supinate and invert the calcaneus, they start to notice that there's a much higher pronation moment occurring. Then now all of a sudden, for the same body weight, same ground reaction force, the axis changes, and now all of a sudden Achilles is going, look, my work has increased twofold, but you didn't get heavier, you're not jumping higher, you're doing the same thing. And so that talks about that frontal plane component, to where not only is the calcaneus moving so uncontrollably, where they call it that whipping mechanism, where the subtendons of the Achilles are straining at the faster calcaneal eversion rates, and then that strain of that twist increases that intratendinous pressure, and that occludes blood flow, and et cetera, et cetera. But what they start to see is that as that subtalar joint deviates, that just starts to really put the Achilles in a bad place. And it's the only thing you really can do is start to do, mechanical interventions at the foot and ankle, whether that be some type of orthoses trying to control that moment, along with trying to figure out how can we get help from these medial ankle stabilizers, Tom, Dick, and Harry. How can we get more help from the synergists, FHL, FDL. And I just think that's not talked about enough, where something that seemingly seems a little bit further away from the Achilles, which is really isn't, because I think sometimes we forget that, the calcaneus the Achilles is attached to the calcaneus. I don't know why. I don't know why we always go Achilles, calf, ankle, but nobody ever goes Achilles, calf, subtalar joint. And I think even just that nuance to kind of changing our mindset maybe allows us to think differently and start to catch things earlier, or maybe get more curious to look at other things.
So I love that. That wasn't war. That was only compliment. I love that. No, you now I learned there. And I tell you what, one thing, and just throwing out to the members on this group, when a patient's in front of you, and I'm still mentoring fellows and things like that, I've seen a consistent pattern with Achilles tendinopathy where the tenderness is where? Medial. Absolutely. 100% medially aspect. And that goes into that tendon. It doesn't do well with the tensioning effect on the medial aspect, right? And that goes into what the really role is of that Achilles. So yes, I love that. And I'm seeing the same thing. Now, and I will say too, is I love how you brought up the idea of the talus. And we did run a few studies. Hate to be the research geek. We're looking at iStim, we're looking at Mulligan MWM. And I tell you what, one thing that really moved the needle for me was looking at the Mulligan MWM closed chain, and then also appreciating the external rotation congruent motion with the talus. I wasn't doing that. I was using belts and it was easier. And you know what? I wasn't getting the same, and I was getting the same effect with you, Terris. But yeah, there are not all manual techniques are created equal with that.
Yeah.
So I would love to share some of the stuff that we've done, because I would say if you improve the dorsiflexion, at least you take away the need to compensate with pronation, which occurs at the subtalar joint.
Yeah.
Now, if probably the most challenging patient I've had is with the foot type, pes planus, and no dorsiflexion restriction. Ouch. So do we say the word orthotics? Possibly, but yes. But yeah, so you take away some of those manual tools. So, for me, now you got to look at they need more stability, right? It's just a bag of bones. They got to be adaptable, but I have to be rigid. And you mentioned a great point. One of the key critical events that I'm looking at is heel off into toe off. So heel off, you do need about 10 degrees of that dorsiflexion, and there you need a supinated foot for a rigid lever to propel off. So if now you're start off in a more planus state, boy, they really got to compensate so much to get in that supinated state and go back to those axes, to really crisscross those axes to get that stability that you need to propel, just to walk, to run, to jump.
Yeah, so much research on the Achilles and the surgical repair and the rehab part of it. But it'd be interesting to see, with all these ruptures that are happening in the NBA, can we measure their subtalar joint on all these players, compare them to the general population to see if there's a big discrepancy, and then put that correlation there? Can you screen every player on the team and look at their subtalar joint motion to see, oh, you might be a higher risk? I know there's many factors that come into play though with that, but it'd be interesting to look at the actual range of motion of these individuals after. Well, it's hard to test them after they rupture, but knowing that they did rupture, there's something wrong.
Yeah. And Justin, to that, there are a couple of things that I'm playing around with right now, and shout out to the podiatry world for putting me on some of these things, because it really wasn't until I dove deep into podiatry where I started to realize that the best biomechanists in the world are podiatrists. And because biomechanics, for some reason, in you guys' field is infused and made important, where, I've done the didactic of PT, I've done the didactic of AT, strength coach, and the biomechanics gets very simple, and it stops at a certain granular level to where podiatrists don't have that luxury to stop, right? Especially a surgeon, right? You don't have the luxury to be like, all right, yeah, I know Newton's laws. I know basic, concave, convex rules, where, it was a podiatrist that actually kind of took me under his wing and started to open my eyes to a lot of these things. And what I started to notice, to your point, was, and I'm sure you've heard this name, Kevin Kirby, in the field. He's a big guy. with his rotational equilibrium theory, right? Where he kind of moved to that versus the root, type of the old way to evaluate the subtalar joint. He's like, man, we got to get these subtalar joints neutral, and we got to make everything, base everything off of a subtalar joint neutral. That's how we're gonna, do an orthoses. That's the goal. If we get the subtalar joint neutral, all problems go away, right? And they, obviously, as time has moved on, and we've got more people who are more passionate, who are, still passionate and still trying to push the profession forward, like a Kevin Kirby, and who landed on that rotational equilibrium theory, where he's going, look, we've got to figure out at what point does the ground reaction force cause our subtalar joint to pronate. And what he started to notice was that, going back to that same thing of the deviated subtalar joint axis, is that we got to do a better job at managing these medial motions. And that's kind of how he came up with his Kirby skive technique. I don't know if you heard of that, but how he kind of changed, the orthoses industry. And then what I started to learn was that there are a couple ways to try to measure that. You got human locomotion, Tom Machad, where he's doing this medial malleolar drift test, where he has a device, and he's looking at, just how much internal rotation and pronation is causing the medial movement of the medial malleolus, and he uses that as a measurement to dictate whether you have a low, high, or normal arch. And then you have this new thing that's kind of developing, and I'm not sure where I'm at with this device, but it's called the Keystone device. I don't know if you heard of that, where they're using a dynamometer, and they're kind of pulling up on the medial side of the calcaneus, and they have a way to measure the forces, and they're looking at what point does your your first metatarsal come off the ground, at what force. And so that's how they're dictating to see if it doesn't take a lot of force to make that first met head come off the ground, then you're this. If it takes a whole lot of force to get this first met head off the ground, and they're trying to make that look almost like a surrogate for what the Achilles is going through, right, as it's going heel off, to see, is this subtalar joint deviated so much that the amount of inversion force that it takes just to lift the heel has skyrocketed. So there's a couple things that people are looking at, but it's not well known, it's not well studied, it's early, especially that Keystone device. It's reliable, but how valid it is, only time will tell on that.
I guess one of the things I'm curious about as well is, obviously we mentioned some of the different joints in the talus extensively that way, but correct me if I'm wrong, but I believe that the tendon itself, the Achilles tendon, is almost like helical in nature. Like it's not just a straight linear path. Like there's some kind of twist and torsion to it as you combine the three soft tissue components that form the tendon, if you will. And I know that's been getting more attention from the interventional side of things, is how do we, train the Achilles to not just act in a sagittal plane manner. Maybe it's more than just plantar flexion. Maybe there's something to that twist and rotational component to the tendon subgroups, if you will, that way. I guess I want to call it like a helical twist or helical path. I might be using those words interchangeably that way, but I'd love to hear more from you all on the actual tendon structure itself and that twisting effect that occurs. One, Justin, obviously what you see when you are repairing these, and how does that help to kind of guide your surgical repair route with the tendons that way, depending on where they're ruptured and so on that way. And obviously from the rehab side of things, like, is there something to this concept of plantar flexion plus rotational forces to train the calf complex, or is that maybe a little bit misguided in our opinion?
Yeah, that torsional area, there's been theories that can be, I mean, that's usually where they rupture, where you see that, histologically. the watershed area, that torsional area where the collagen fibers do change direction. I don't think we've ever fully accepted that that is the sole reason, of course, and I think we all agree that that's not a sole reason why, but maybe it's a contributing factor that the collagen fibers are changing direction, and it seems too convenient that that's where it ruptures. But as far as the surgical repair of that, it is difficult to see direction of tendon, fibers after it's ruptured because, a lot of times it is a mess. But what we've learned, as we've progressed with fixing these, which technically aren't difficult, they're one of the easiest surgeries you can do. You go end to end, put strong locking stitches in. But one thing that we've realized is that we know that the weakest part of the tendon is obviously where it ruptured. And when we look at, surgical repair and studies with load to failure and cyclical loading, we found that the weakest part of the surgeon's repair is the surgical knots when we put the stitches in. And the thought was, we've been putting the knots at the rupture site for so long, and it's like, well, why would you do that, right? As a surgeon, why would you put the weakest part of your repair at the weakest part of the tendon? Which is why we kind of drifted away from tying down at the rupture site, where we actually pass knots, proximal and distal. Or what I do, which is a lot of people are doing now, is you pass those suture strands into the calcaneus and you anchor them in. So there is no knot. You are actually passing through and making that a stronger construct.
Do you guys have enough time to kind of see the different outcomes with those different surgical strategies or techniques? Because we all know that after an Achilles repair, there are changes to the tissue, rightfully so. And a lot of times we see that it's really difficult for athletes to regain that top portion of their plantar flexion, where I guess the compliance of the tendon and the stiffness makeup of the tendon has changed. Do you notice any different with outcomes, whether you're going all the way down to the calcaneus versus just doing it kind of mid portion?
Honestly, no. I can tell you that as far as long-term outcomes, I don't think there's a lot of good research on that. Um, Personally, like, there was always this one good surgeon that would always give a presentation, and he always talked about N equals 1, right? He talked about the power of your studies, high number, high number. And when the patient's sitting in front of you, they don't care. They don't care about any of that research. 1, N equals 1, fix me. So I can tell you clinically, just for my patients, when I've tied them down into the calcaneus, I've had them plantar flex at 4 weeks on their toes, which was absurd to me. And I was very worried doing that. But when you think about it, like, I shouldn't be worried. If they're dorsiflexing to like 20 degrees 4 weeks after surgery, I would be like, what are you doing? Um, but we do know, there definitely is fibrosis, right? There is collagen remodeling, but then there's that theory of, we know that eccentric loading could help remodel a tendon, right? So then there's that debate of should physical therapy start after the Achilles tendon repair? And traditionally, I think we've been behind the curve on PT. I don't know how it is in the professional world, because I know they're getting PT like right away. But in the real world, outside of professional athletes, surgeons have delayed it. They've delayed the PT on the tendon because the surgeon didn't want to mess up their repair, and they were worried and worried and worried. I don't worry. I get them in at 2 weeks after the stitches come out, and at PT I get them going. But as far as like their plantar flexion, push off, toe off, I've been pleased with mine so far. But the ones that I've done, I've done a few college, I've done a few police officers, people that are active, no professional athletes. So these people aren't, going high, crazy level. I mean, some of the college athletes are, but it's a tough injury. It's devastating. It's a devastating injury when you look at it in the grand scheme of things. When you look at the outcomes and the statistics long term, it's tough. It's a tough injury.
The other question I have is a follow-up to that. You mentioned the eccentric loading, and that's come up a few times. Where do you have them kind of go to with that? Like, are you just having them come back down to neutral? Because I've seen some other stuff popping up about how, hey, we almost need to get into a dorsiflexed position in order to load the tendon adequately to cause adaptation, almost from like a slant board heel raise, if you will, instead of just going from the ground back to neutral. But obviously, too early on, following an Achilles, we don't want to force the dorsiflexion. We don't want extra stress, extra stretch on that tissue because we know it's probably going to elongate over time that way. So where do we kind of balance that from a eccentric load to the tendon being good for remodeling, but also too much into that dorsiflexion range too early is probably not a good thing for that tendon either.
That's a good answer for the PT population, but we know that you don't have to dorsiflex past neutral to eccentrically load a muscle, right? So we know that. But yes, I'm worried about excessive dorsiflexion too early because you could elongate the tendon and you'll lose your muscle push off. So that is definite. I'll give you the historic. Historic was I had a good friend, he's a PT, and he would rehab these, and he would see the patients Planaflex cast 6 weeks, right? And now they're playing catch up, right? Cast comes off, and he's like, okay, I got to get him to like neutral. It's going to take me like a good 4 weeks to just get him to neutral. So now we're talking about 10 weeks post surgery. And then when he ruptured his playing basketball, he called me and he said, I want you to fix it. I've seen the other guys and what they're doing. He's like, I want, I want a different rehab protocol. I was like, all right, let's do it. I was like, but I said, you need to track it for me. You need to take your videos because you're the PT and you're the patient. And we did. So traditionally 6 weeks plantarflexion casting, and then you're playing catch up to get to neutral. Whoever knows that, how long that takes. But for me personally, I do, gravity equinus, splinting, for 2 weeks, and then cam boot, wedge, weight bearing, and then I want them at neutral at 4 weeks. And then past 4 weeks, going into week 6, I want them dorsiflex past neutral. I don't want them to be aggressive with it. But as far as like plantarflexion strength, I want them going like right away. And with the eccentric loading, like, the theory is always it's also that stress shielding complex, right? That stress shielding that people always forget, like like in the posterior compartment, it's not just the Achilles, it's not just the gastroc and the soleus, it's the FHL, FDL, tibialis posterior, like those things. If you eccentrically load those things, you can stress shield, and I do think it makes sense, and you can protect your Achilles tendon. You can help increase the tension there. So I think that's all important. But I think the problem we always have as surgeons is that the techniques to fix things, the implants, the way we're doing them is progressing so far, but our rehab protocol for the surgeon's mindset is lagging still, right? And I give this slide up there, and I said, who has a flip phone? Like, which surgeon has a flip phone? So you'll get the latest technology in your car. You'll get the latest technology on your phone. You'll use the latest technology in your surgeries, but you still won't progress to do some kind of accelerated rehab that is, you know what I mean? So surgeons are lacking. We're getting better. We're getting better. I don't want to like throw everybody under the bus and get in trouble here, but we're getting better.
I'm glad, Dan, you didn't invite ChatGPT to this call.
Yeah, Justin, I think that what you're saying about the surgeon and the disconnect between the surgeon and the rehabs and the rehab therapist, I'm seeing that a lot. Even right now. As I was actually hanging out with a surgical podiatrist last week, and we talked about all the different surgeries, and we talked about the protocols, and it's kind of like this handoff where it's like the surgeon really dictates the first couple of weeks because they're like, you bet not F up my surgery. And and I'm like, well, I'm not sure if there's conversations being had about, well, what exactly would occur? Because I think when people say start PT, they don't even give them I guess, an explanation of, well, what do you actually mean? Because it could just be me doing stuff with their knee. It could be me going, okay, well, let me make sure I can get them all full hip external internal rotation. Let me make sure, and then let's make sure that patella is moving correctly. Let's making sure that we got we can move towards full internal external rotation of the knee, right? Because all that stuff is going to impact our ankle plantar flexion, ankle dorsiflexion, all that stuff is going to impact it. So we can start as soon as we get the go, but I think there may not be practitioners even taking that approach, because as soon as they get an Achilles, which, if you get a surgery, you got to deal with what happened in the surgery. But I think, while I'm waiting for an opportune time to start loading this tissue and stress the tissue and still keep the surgeon happy within these timelines, we can still take that pathomechanical approach where I know that the ankle is a mitered hinge. I know that every single thing that happens in the ankle has to happen in the knee and vice versa. And you can't escape that. And I know for a fact I can get them going on something, even if it's 90% manual, right? If it's 90% soft tissue, we can get them going sooner than later, because again, we're trying to still negate those negative effects that every injury is going to have, whether they get surgerized or not. There's still going to be these changes to the tissue and these compensatory movement patterns, Mike, that you love to talk about so much, that's going to occur. So I'm trying to reduce as much as I can as soon as possible. And I think we can get both of those done. I don't have to have them doing crazy stuff. My hands can do most of the work, and we can maybe if it's just getting the CNS calmed down, that can just be enough just to start.
One thing I've learned as I've progressed in my career, which I didn't know in the beginning, was that every physical therapist is different. Even specialized. And when I get an Achilles rupture, I know who to send them to, right? I'm not sending them to any general PT, but I know which ones to send them to. And to also hit your point, every sports PT that I pretty much know, they got my cell phone number. First name basis. They text me, right? That's what we do. You have to communicate. But I know on the other end, for PTs, it is difficult to get in contact with the surgeon sometimes. Sometimes you'll leave a message, and it won't get returned, and you have a question. But no, I understand that. And that's why, no, they text me. Text me is the easiest way. I respond right away. Yep. So that, having that good rapport with the surgeon and PT is important. It does make everyone's work space and work environment better, and it benefits the patient, the athlete. That's the main thing.
Yeah, the more conversations we have like this is what pushes the field forward. This is what makes surgery protocols update. This is what, this is how we continue to progress. And when you talked about, your metaphor of the flip phone, this is the way forward. So I'm honestly, I feel grateful that we're having these conversations, because I can take something from this conversation, take it back to my sphere of influence, and you as well. So I think shout out to Dan and making this happen.
Absolutely. Second that.
Just another day in paradise for me. But guys, I feel like we can probably talk about this stuff literally all day long. I mean, I think the three of you should collab together, maybe make a course or something at this point. I would sign up for it in a heartbeat. My goodness. But anything we missed, or any other kind of closing thoughts or remarks from today?
No, I mean, the collaboration is the key, right? We're always learning. I learned new stuff today. Things I didn't really think about, but that expands my knowledge. Is supposed to benefit and help to move the profession forward, So collaboration, that's why I got to keep doing these things. I appreciate it, Dan.
Lifelong learning. Keep it going.
Yeah, I mean, keep being a student of the game, understanding that, man, all these joints, tissues, nervous system, all connected. And there, as soon as you think you know it all, there's another level right underneath it that you got to kind of uncover to continue to level up as a practitioner, especially when you get that one-off patient where you're like, oof, my usual tricks ain't really tricking right now. Those are a lot of the cases where I feel like, you grow the most. So I think, yeah, like you said, Mike, just lifelong learning. And to add context to lifelong learning, being very rigorous with your learning, and not just settling for the status quo. Continue to push the status quo forward, challenge, question, just trying to continue to figure out, what exactly is truth, what are first principles, and what are some things that are just true right now, right? Because we know as research continues to go, things are going to change.
Yeah, absolutely. And for people who want to find out more about you all, booming online social media presences, Terris on Instagram, Lehr on MySpace, where can they find you all at online?
Just playing my Atari games back in the 80s, so. No, you can find me, with the email from Messiah University. I'm on there. I won't even mention Facebook.
Yeah, I'm on Instagram, Justin Lewis _foot surgery. That's where you can find me.
I'm on LinkedIn as well. So, yeah, some credible space.
Yeah, you guys can find me on Instagram as well, Terris Hightower at Terris Hightower, and especially on LinkedIn. I'm a LinkedIn guy, so I'm always active. I'm always posting. I'm always looking to collab with like-minded individuals there. So, and I appreciate you, Dan.
Yeah, that's awesome. Thank you all again for your time and all the insights that you shared today. I had a lot of fun and learned a ton from you all, and looking forward to our next conversation with you all that way. Thanks again.
Thank you.
Thanks.
Thanks, guys.